in 2011 at the IS conference, although the results were known before, but the conference, of course, gave. And the second thing is that these results actually reinforce what WHO recommended recently, that actually was not taken well by all environments. Also thinking at risk compensation or thinking that the introduction of PrEP would drive people wild, which is, on the contrary, not true. So I think it's these and what will be presented today is very, very important. Thank you very much. Then the questions. François will talk about a different aspect of using antiretrovirals for prevention. This is the use of antiretrovirals in already infected persons to diminish the spread. And it doesn't have results because, of course, this is a trial that will last for some years. But I think you will provide some data on the feasibility, on the acceptability of test and treat, which is a strategy which is being tested in different trials, but not many because of their complexity. So, François, can you explain where you are with your trial?
Sure. So good afternoon. So I'm François Dabis. I'm professor of public health in France, and I am one of the investigators of this ANRS treatment as prevention trial. So I'll abbreviate this as TASP. And this is an international study group which is exploring the TASP hypothesis in rural South Africa. So the trial sponsor is the French agency ANRS, and the funding comes from several sources, including the Bill and Melinda Gates Foundation. We conduct, of course, this project in partnership with the South African authorities, especially those of the province of KwaZulu-Natal, and there will be a presentation by my colleagues Collins Iwuji, who is here tomorrow afternoon at 2:30 p.m. in the plenary room 3. There is also a press release that will be available to you at the end of this conference. So as a background, the issue here is we know that ART can prevent sexual transmission in several contexts, but we don't know yet whether we can really reduce the acquisition of HIV infection at population level and in a population when we are proposing a universal test and treat approach. So this has never been done so far at the global level. So the best way to really demonstrate scientifically that this TASP hypothesis holds true is to conduct an experiment at population level and go well beyond the use of ART according to WHO and national guidelines. So to my knowledge, there are currently 4 trials of this kind that are being conducted through Southern and Eastern Africa, but the ANRS trial that is presented here in Melbourne is the first one to report on the feasibility and acceptability findings of what we have called the phase 1 of our project. So we have indeed decided very carefully to investigate feasibility and acceptability over the past 2 years before going any further in the conduct of the large-scale trial. But I can already say that the indicators that we obtained were very good, and therefore we are moving on now to the full trial. So just to explain to you what we did in the design, we are working in a district in rural South Africa in the province of KwaZulu-Natal. The prevalence, to give you an idea, is about 24% among adults living in this area. And in this rural district, we have delineated 22 groups of about 1,000 people each, 1,000 residents each. The study team goes door to door to offer HIV counseling and testing to all the adults who want to do do so, and we repeat this offer of home testing every 6 months. We have then randomized 11 of these clusters, what I call this group or clusters, to receive the universal ART interventions, meaning that we are offering them, the positives of course, immediate and universal ART to all those who want and who are informed of their status. Whereas in the 11 other groups, what we are doing is that we are offering ART according to the South African national guidelines, meaning at the moment below 350 CD4 counts plus special groups. You have to note that in South Africa and in this region in particular, ART was introduced much before we did our trial, so there is already a background of ART use in this community, and we are really topping up on this existing HIV care and treatment program, and we are not starting from scratch. But we are enhancing the overall system of delivering ART. We are even opening task clinics very close to the people, so they don't need to travel a lot to get new services. So what have we learned over the past 2 years in which we carefully investigated this approach in 10 of these clusters, so 5 intervention and 5 controls, 5 key results that I will highlight for you. First of all, we managed to contact about 10,000 people in these communities, and the very good news is that 95% of them accepted to participate in our trial. Second, we achieved high initial and repeat HIV ascertainment at home. To give you exact figures that we are going to give tomorrow, 82% of the people contacted at first run accepted to be tested, and when we came back for the negatives 6 months later, 85% of the negatives accepted again to be tested. So we have very high acceptance rate of testing at home in this community. Third, as I said, the ART use was already in existence in this community, and we discovered that the ART coverage at the beginning of the trial was about 40% of all those HIV positive in this community. So in South Africa, even in rural sites, there is already ART use, and this is of course a good start because we would not do the trial in another way. The fourth result was that ART initiation among those that we diagnosed for the first time during the trial was not as immediate as we thought. In fact, immediately after we announced new people that they were positive, about 34% of them accepted to start treatment. And in the year that follows their announcement, this is increased to 48%. But that really means that linkage to care and treatment initiation are still incomplete despite our efforts to go towards the community. However, the last and fifth information that I want to share is that when we create clinics close to the people and then we offer people to go to this clinic, they tend to go in the right direction, meaning that ART initiation in this clinic worked reasonably well. And in the intervention clusters, remember in the intervention clusters we offered people to have immediate treatment. Well, those who went to these task clinics immediately, 85% of them accepted to be treated. So that's very good, but that doesn't work for everybody because not everybody wants to go at this clinic at the moment. And remember, we are dividing this population into this intervention cluster into those who need the treatment according to the South African guidelines and those who will receive it on the top. And in this subgroup that should receive it on the top, this proportion that accepted to be treated was 85%. That's even slightly better. So in conclusion, we have demonstrated on a reasonably large scale already that what we call the treatment as prevention approach, we could also call it universal test and treat, was acceptable and it was quite feasible. And remember, this is a heavily affected population. This is a relatively hard to reach population, and the coverage was very incomplete when we started the trial. So most of our indicators measures of success are going in the right direction. In fact, they were even very close to what we call the trial assumptions, the assumptions on which we made the trial design. And the trial was designed to, in the end, be able to demonstrate that there will be, with universal test and treat, a reduction in incidence in acquisition of new infections of 34%. And everything we observed in this very first phase fits with our original assumptions. So we are not quite right at the stage where we can demonstrate that there is efficacy or effectiveness, as we say, in the field. But based on the findings that I just described and that Collins will present tomorrow, the trial governing bodies and the sponsor of the trial have decided to move up and to move to full scale of the trial, and we have started to open new clusters just last month. And so in the next 2 years, we should have the final results with regard to effectiveness, so meaning whether the trial and the universal test and treat approach is really reducing acquisition of new infections in these communities. Thank you.
Thank you very much, François. I think you get the importance of these initial results because, as usual, as also Mark Dybul said today, first of all, not one intervention will be enough for the world. We need to have combined approaches, and test and treat will be one, pre-exposure will be another one, and now we are going to a third intervention that proved efficacious in a clinical trial, which is circumcision. You remember the Orange trial is not the only one, but maybe the first to prove. We were skeptical, let me say, need to confess, sometimes before, but fortunately there was a group of believers. And that's again an INRS sponsored trial. Now what we have is, again, like for the IPREX, we have a kind of follow-up of the initial trial, because you know that the initial trial proved that it was protective for men that are circumcised. But now they are looking at the impact on women having sex with circumcised men, which is of paramount importance. So thank you. I'm sorry, I didn't want to just talk. Maybe I said everything, but please go ahead.
Thank you. Hi, everybody. So yeah, since 2001, the INRS is funding research programs in Orange Farm. That research programs are coordinated by Professor Bertrand Vert. Orange Farm is a township near from Johannesburg in South Africa, with about 110,000 adults. And the township acknowledged one of the highest HIV prevalence in the world, together with KwaZulu-Natal. About 20% of adults are infected with HIV, and the prevalence peaks to nearly 50% among women aged 30 to 35. And as Stefano said, Orange Farm has been a main research setting on voluntary medical male circumcision, VMMC. It gave the first proof of concept that VMMC can reduce the risk of HIV acquisition among men in the framework of a trial. And then it was not really a follow-up, it was a generalization, a rollout of circumcision in real-world situation. And the example of Orange Farm has shown that when VMMC is freely offered in population, the access and the uptake can be actually high and rapid. So it is feasible to have a rapid and large uptake of circumcision, and it showed also that men were mostly in favor to circumcision, and results of the rollout showed that VMMC reduced also the risk of HIV acquisition in the real-world situation. And we've seen that circumcised men were less infected with HIV than uncircumcised men in the community of Orange Farm. But now the question was about women. What about women? Because no previous study documented any effect of male circumcision on the male to female circumcision. It means that a man who is infected with HIV has the same risk to transmit, whether he's circumcised or not. But, however, if circumcised men are less infected with HIV, thus women having circumcised partners should be less exposed to the virus. And thus we expect an indirect protection of circumcision among women. That was predicted by models, but that has never been shown on the basis of data collected in population. So that's what we wanted to assess, and we conducted different surveys among more than 4,500 women aged 50 to 49. And the first results showed that, as for men, women were highly in favor of.
He's a member of the Global Forum of Men Having Sex with Men. I think it's very important to hear something from their report that covers the challenges, in the real life challenges of all of these interventions, because we, academia, we do trials, we think, we do projections, but then some of these interventions have to deal with the real life of the persons. So thank you for giving us results of your report, of your...
Thank you. Can you hear me? Good afternoon, everyone. My name is Keleto Makofani, and I'm a Senior Research and Programs Associate at the Global Forum on MSM and HIV. The Global Forum is a global network of communities of men who have sex with men, and we've done a lot of work on advocacy at the global level and more at the country level on HIV amongst our communities. I'm also a member of the World Health Organization's guidelines on key populations in HIV, which just made the PrEP recommendation and was launched a few weeks ago. I wanted to start by saying I really welcome these findings. I think it's an exciting time in terms of the biomedicine, and it's an exciting time in terms of the tools we have to address the epidemic. Specifically, I welcome the finding that people who have higher sexual risk self-select into PrEP. And I'm surprised that Dr. Grant is surprised at our agency. I'm surprised that we make decisions about our health if we have the information and if we have the resources. And my talk is really around having access to those resources. Around the world, men who have sex with men face multiple vulnerabilities and multiple challenges, and HIV is only one of them. And our response to HIV globally amongst men who have sex with men has been poor, has been absolutely poor. And it hasn't been poor because of the biomedicine, I would contend. We have condoms and we have lubricants, and we're doing a really bad job at delivering condoms and lubricants to men who have sex with men. Not entering into arguments around whether people use condoms and lubricants if they have access to them, but even laying your hands on them and laying your hands on information around HIV is really difficult. So this is a time to really invite sober conversations about where we are and where we want to go, and to really talk about the challenges and enter into conversation with our scientists and our community members and our healthcare providers around how do we deliver the things that are so exciting, that are so efficacious, but we don't know how effective they are in the real world yet. In the real world, that accounts for homophobia, right? So we launched we launched a publication which speaks to some of these challenges and really looks at how people access services, what are the social determinants of that access to services, and what are interventions that could be made to alleviate some of the barriers that stop men who have sex with men from accessing services. And it's really focused in Africa, in sub-Saharan Africa. We've had a global survey of around 5,700 people, and we had a subsample of 600 people from different parts of sub-Saharan Africa. And that survey explores what level of access people have, what barriers they have, and what facilitators improve access, but critically, what interventions community-based organizations across Africa are making, even at a really small scale, to alleviate some of the barriers. We found that there are kind of three different domains to think about, or really important domains. One is, what is the relationship between men who have sex with men and their healthcare providers? Another is, what is the level of homophobia and homophobic violence in the community around the healthcare delivery site? And the third, which is really key, is how does the strength of the local gay community or the local community of men who have sex with men, whatever they call themselves, how does the strength of that community impact on access to services. And I won't go into the results. They're all in a publication, which I have some copies here if you're interested. But so in this first domain of relationship with provider, we found that people who have the highest comfort with their provider compared to people who had the lowest level of comfort had 5 times higher access to condoms, 3 times higher access to testing, 15 times higher access to HIV education. And on the flip side, those who had the lowest frequency of past stigmatizing experiences with their provider had double the level of access to testing as those who had the highest level of stigmatizing encounters. So again, as we talk about PrEP and TASP, let's talk about what interventions are necessary to put in place to support these interventions, or to make them possible, not to support them, but to make them possible in the real world. Again, it's also important, and some of this work, it sounds a little abstract, I know, when you talk about enablers, critical enablers and barriers, it's a little, but in this report, again, we have very concrete interventions that community-based organizations do. So for instance, when it comes to the relationship with men who have sex with men and their provider, community-based organizations will either provide their own services, steering men away from a dangerous healthcare system, or they will navigate their clients through the system by sensitizing providers, by training providers, by forming relationships, by referring to specific people and following up to make sure that the experiences were good. So there are a range of interventions that we need to support and that we need the scientific community to also engage with. So at the same time as you test the effectiveness of PrEP, you need to test what an anti-violence intervention does in the context of PrEP, or how an intervention that creates community, that creates spaces for people to speak about their sexual lives, to meet, to not talk about HIV. How does that community support a program that delivers PrEP or TASP? And I think we're in this moment now. The World Health Organization guidelines, which have been really poorly covered in the media, I hope we really engage with the nuances of those guidelines, because I think they're excellent. And PrEP is not the only story in those guidelines. And the story that was told about PrEP is unfortunate, because that was not the recommendation. It wasn't the recommendation that everyone should take PrEP. And it's consistent with the finding that men who have high sexual risk will self-select into PrEP. The guidelines are really to enable that, to say in the healthcare system there should be somewhere where PrEP is accessible. But besides the PrEP recommendation, there's an entire chapter of those guidelines which is dedicated to thinking through the social environment of key populations, including men who have sex with men, and analyzing it and picking out interventions that change the social environment. So there's a recommendation by the World Health Organization for the first time that governments need to decriminalize the behaviors of key populations. That is a very important recommendation. And that recommendation goes to departments of health. It says departments of health have an advocacy role in making it happen. Anyway, I think I might be over my time. So I welcome your questions.
So thank you very much. I think what you said is very important, and the last part regarding criminalization, I think, is of paramount importance. And as a chair or co-chair of the 2013 guidelines on treatment, again, we tried also in that guidelines to take into consideration not only the clinical aspects, but also the implementation aspects and the social environment where all these scientific insights can then be applied in practice. And so I would like to give now the floor to questions. There are microphones there, and I see already one. And
shall I? First of all, Mr. Makofana, excuse me, Jan Herblans, Dutch National Radio. Mr. Makofana, you make me wonder how early you can be a senior researcher. My question is to François Davis. I didn't hear you mention the average viral load worth of the people that were in your target group where people were taking up treatment.
I didn't mention this because the principle of the universal test and treat approach is that we will offer the treatment to everybody in the community. At the moment, we do not have such data as the community viral load or any viral load information to share, unfortunately. But we will, of course.
Okay.
Yeah, Michael Smith, MedPage today. I actually have a couple of questions, if you don't mind. First one is to Professor Dabi. I may have misheard, or I'm not quite clear on the difference between the intervention and the control clusters. Is it in the intervention clusters you will treat anybody regardless of of national guidelines, whereas otherwise it'll be guidelines, or what's the difference?
That's exactly that. The South African guidelines are very clear at the moment. They are restricting and they are slightly below what the WHO guidelines are. But basically, this is treating people according to their strict criteria. Whereas in the intervention clusters, we are offering treatment to all people as long as they are positive and want to be treated.
Okay.
No, it's in South Africa. This is 350 plus specific groups, like pregnant women, TB, etc.
My second question is actually for I'm assuming Dr. Jean, and that is I thought I heard you say that the incidence data you have is actually based only on a mathematical model. You don't actually have sort of prospective incidence data in your cohort.
Okay. Yeah, that's true. That's model incidence, but that's a model relying on existing and observed data of prevalence. So it relies only on age-specific prevalence data. So that's model, but relying on observed data. And that's true, that's one of the limits of the study, but we've just terminated the fieldwork of seroconversion study. So in some months, I hope we could complete these results with data on measured HIV incidence.
Okay, thank you. That's very interesting. And my final question actually is for you, Stefano, if I may. Just you said at the beginning, and people talked about the WHO guidelines, but you were referring to them in the context of the PrEP study. And I just wondered if you could elaborate a little bit more. I wasn't quite clear on how the two interact, really. So maybe you could just talk a little bit more about that.
No, actually, I was not talking about the guidelines in the context of PrEP. I was saying that even when we did the old one in 2013, we tried also to add not only science or scientific evidence, but the implementation aspects. As I think the new guidelines on key affected populations did very well, even in an even better way, because it was even more needed. I mean, to address these barriers and discriminatory conditions. So, no, the issue of the guidelines, of course, comes out also for treatment as prevention, because, of course, now with the increase of the threshold, let's say, and in decrease of the population that can access treatment independently of CD4, the numbers that may access is huge already. So the added portion of patients that will be treated immediately after being tested may be not immense, let's say. But that's something that I'm not here to address this, but it might be a challenge in a sense to really test the test and treat approach in the future. So sorry, but it's not my press conference, it's their press conference. I have questions here, I think.
Hello. Yes. First of all, my name is Ya Simpson, Sister Ya. I'm here representing the Black AIDS Institute, and as well as I'm from Chicago. My question really has a lot to do with the community, and I really appreciate your presence being on the board, because I think, as I applaud the whole aspect of circumcision, which is more medicalized in a sense, right, or at least, you know, trying to get people to do it, and I really appreciate having the indirect impact on women being studied. That is awesome. Thank you very much for looking at that. But what I want to address is clinical research in the community and how it's seen, because PrEP in essence, is taking medication, right, for something you don't have, you want to prevent from getting. So what is the community's response as far as the stigma? Because you already have a stigma for taking the medication because you're positive. Now you're going to have something else that you're going to take for not being positive. And how is that being infused in the community? Because in the States, sometimes we're kind of reluctant because the pharmaceutical companies are the ones making the money off of this, but we're not really seeing what the benefits as a whole. I'm not saying there are none, don't misquote me, but in that, you know, now we're taking more medicine for something else. So I really wanted to get the community's insight into this, because so often clinical research is done outside the community-based participatory research model, which I promote. So I wanted to hear how that, is there a stigma to it? Are people embracing it, or are they feeling like we can't afford it?
So I think you've asked some questions that are important that we don't really have good information on for me to speak on behalf of community, because speaking for community doesn't mean because I'm gay and I live in the world that I can kind of just channel what the community thinks. We also do research, and there's a false dichotomy between researchers and community. So some really important questions. We're doing another round of the survey, and in this round we're trying to think a little more around the cascade, the clinical cascade, and what are the things that drop people out. So if I'm living with HIV and I have my meds, do I hide them when I'm at home? In my community, does HIV meds indicate gayness, and is that a problem? And will PrEP indicate gayness? So yeah, we're there with you. I also think, I also hesitate to have like a war between biomedicine and community, and is biomedicine trying to rip off community? I think there's a lot of engagement and education we need to do about PrEP. There's some people who don't like condoms. There's some people who like to fuck, and who like to fuck bareback. And those people should be able to make decisions about how they're going to protect themselves. And there's a little bit of fear-mongering around PrEP and around other biomedical interventions, and I think we need to stop that and just engage with the science and have that discussion. Is it beneficial to the community? But have it with the right information. So I think I've given non-answers to your question, but I think they're really good questions. Thank you.
Can I ask also Rob to give some views on this criticism, or it's not a criticism, it's an issue raised?
Well, I think it's actually an extremely important question, and clearly PrEP users have been targeted by very critical and judgmental people who have called them Truvada whores, they've called them irresponsible, they've called them a lot of names. But I think stigma is a social process, and as such it changes over time. A year ago, I could not find any PrEP user who was willing to speak out publicly using their full name. Pedro Goycochea, who's in the room here, made a movie of PrEP users, and for the first time ever, about last year, people were willing to speak out on film using their first names. Well, now it's very different. PrEP users are happy to speak out in the press. You can find PrEP users here who will tell you how proud they are to be protecting themselves and their partners using pre-exposure prophylaxis. So things change. Stigma can change.
Can I also just add? Sorry, can I also just add and say that stigma around PrEP is definitely one of the considerations. But there's a whole. We did a values and preferences study as part of the WHO guidelines process. So the values and preferences of our constituents as regards to PrEP, and one of the things that came out was that there's kind of there are ethical questions around in a situation where people who are living with HIV, who need access to meds, who don't have access to meds, in that situation, how do you engage with PrEP amongst people who are not living with HIV, and how do you kind of, so if my neighbor is HIV positive and dying or getting sick, and I'm on PrEP, how do we as a community deal with that kind of contradiction? And so I hope what will happen from these findings and the guidelines is that within countries and within communities, we can start having conversations around, okay, PrEP is now available as a tool but ethically, socially, how do we, as a community, organize around it? How do we distribute it?
Yeah, thank you very much. Because Francois, we have also. Can we wait for two, or is it specific for that?
I was going to say that what the dialogue that just happened is very relevant to TASP issues as well. And in fact, we decided to do this trial in this community after almost a year of in-depth discussions with the community leaders, and also with qualitative studies to really document exactly what you were fearing. And in fact, we are also exploring in this first phase that I just described exactly the issue of stigma, discrimination, change in behaviors, and we have all this data to be now explored, because this is critically important as well.
And false moralism that also we had in our country, for example, that saying why should people take medicines instead of having a different behavior, and not considering the benefit for the society of PrEP. In the long term. So in a sense, there's been a lot of discussions even into the community against the guidelines, which was completely wrong. But maybe because we are from Italy. Two questions.
Hi, I'm David Alexander from the Star Observer. My wonderful colleague Pierre stole one of my questions about stigma. But going on from that, do you think there's any lessons that the MSN community, in regards to PrEP, taking medication for something you don't have, essentially, to prevent getting it? Do you think there's any lessons that that community can learn, and introducing that message to that they can learn from the introduction of the pill? Because obviously we know that when that's first started, women who chose to take that face stigma as well. Do you think there's any similarities that can be drawn upon in introducing PrEP?
All right.
Would answer you.
I think there's an abundance of parallels between the advent of the birth control pill and medications for preventing HIV acquisition. In both cases, there was an enormous amount of stigma and suspicion of people who wanted to use the pill. They were accused of being irresponsible sexually. But I think that in both cases, we've really seen how women in the 60s and men who have sex with men more recently have been able to stand up to that kind of criticism and insist on their human rights to conduct themselves safely in the manner that works best for them.
And also that it may apply to statins for primary prevention. Some of us take statin. I take statin for primary prevention and while I could also just eat salads and and run, and so it's the same. I mean, the cost efficacy of PrEP is far lower or better than having statin for primary prevention. Sorry, but that's important because it's a false moralism, that preventing. So I think we have a question, and then we come back. Remember the embargo. It's everything was said here cannot come out until the date I will give you. The hour.
Yes, Gus Cairns, AIDS Map, and I should also say I actually am helping to run a PrEP study in the UK. I'm picking up a sort of general theme here, which is that we may have this new variety of interventions, but that not everyone offered them actually choose to use them. So Francois, only a third of the people offered immediate treatment actually took it up, and 48% in a year. Bob, I know that if people took at least 4 doses a week of PrEP, then it was extremely effective. But not everybody did that. I think possibly only a minority. I can't remember. And obviously, getting guys to get circumcised has proven to be quite a challenging task in some parts of Africa. So the agency you talk about is unfortunately sometimes the agency to decide not to use the intervention. And I'm wondering how this kind of goes with not so much the WHO guidelines, which I think are fantastic, but more the UNAIDS targets, which sort of seem to assume that everybody who's going to, is going to want to test and is going to want treatment if they're positive and all that sort of thing. I wanted to make a little comment as well to Sister Yar. I think community engagement is absolutely key. I think there's been some fantastic community engagements around gay men, like the Damon Jacobs Facebook page, which is a genuinely exciting community resource, but I'd love to see more for women and other groups taking PrEP as well. I think, it's absolutely key to the acceptance of this method. Thanks.
It was almost a very welcome comment, more than a question maybe, or you want to answer, Rob? Yeah.
Well, Gus, thank you for the comment, and you're right. We have a long way to go in mobilizing people to utilize some sort of protective means. I think that what we know from other settings is that choice and having several attractive choices can make a difference for people. So some people will choose to protect themselves by assuring that their partners are treated. Others may choose PrEP. Others will choose condoms. Others will negotiate safety. The beauty of the current era is that we have more and more choices, and it's just like contraception. There isn't one size fits all for contraceptives. We like having a lot of diversity of products such that women and their partners can choose how best to manage their family expectations. It's going to be the same with HIV. Can we have a portfolio of attractive means and allow people to choose one or two things that work best for them? But in terms of lack of uptake of these things, I mean, come on, let's get real. I mean, we have not been clear about how well these things work when they're used. We've given lowball estimates of efficacy. In fact, we don't see anyone becoming infected who uses PrEP consistently. And by consistently, I mean not necessarily every day, but at least 4 times a week. We've also imagined that these drugs are very, very toxic when, in fact, antiretroviral medication has become much safer over the last 25 years since we first started using therapy for HIV. And in our PrEP studies, we're not seeing any lipodystrophy. We're not seeing any body fat changes. And the only 1 in 200 have an abnormal blood test for kidney function. That abnormal blood test normalizes when people stop PrEP, and then they can actually restart it, and they do fine after that. So these drugs for PrEP and for HIV treatment are so much safer than we're thinking. Let's face it, I mean, how much demand for prevention services do we expect to get when we call people Truvada whores? I mean, we have to ease up on the stigma and the judgment if we really want people to step up and protect themselves and their lovers.
And if I may, I would just also say, Gus, that I don't think in a context where everyone has information and access to these different options, it's fortunate or unfortunate that they choose some and not others. I just think it's real, right? Like, I think we should stop thinking about interventions in silos and I have this intervention, only 30% people want it, therefore 70% are gonna, because in reality, all of us think about your own sex lives. Most of us have them, I guess, but you make decisions around, like, today, am I going to take PrEP or not? Am I going to use a condom or not? Am I going to get circumcised or not? So it's around the combination of interventions that each individual wants to take on. And maybe if we modeled in that way, like, what do I choose and what does that mean for the impact of the epidemic? And so I also would like us to stop thinking about combination prevention as this thing of the future. Like, all of us have been doing combination prevention for a long time, and serial sorting, serial adaptation were things that were invented by people who were having sex and then discovered by scientists and put in academic journals. So, let's engage with our own sex lives when you talk about the sex of other people and understand that all of us are always optimizing.
Thank you.
Just wanted to add some.
Thank you very much. I think it was a very thoughtful session. I need to close because if not, they will fire me. No, but before you go, again, they will fire me if I don't remember the embargo. Tuesday, today, 4:30 is for the